the EMCR committees, and I'm sure the topics would get everyone's interest on this. For those who don't know me, I'm Solomon Yu. I'm a current president of the ANZ SSFR. And it's actually an honor to be here to be able to open the sessions for you. As everyone knows, frailty and sarcopenia has been quite a big challenge for a long time, although in the last few years, because of the tsunami of the aging populations, it's become quite critical. And there's been lots of activities and research into these areas of things. And you probably, if you follow the literature, it's been sort of a great expansion of the last 10 years. So if you look at sarcopenia, that's increased over 2,000, 3,000 per year of publications. It's probably still going up for the moment. So it is an important topic. And I like the topic today with Jennifer and Anthony and the committees group that sort of came up, frailty sarcopenia as core business. And it is indeed a core business. And we really should think about that in everything that we do. So that's actually the topics today. So without further ado, I really want to sort of let everyone else have the opportunity to talk. So I'm going to hand the time down to Jennifer and officially open the sessions.
Thank you very much. And thank you very much, Solomon, for opening. And thank you very much to everyone for attending today. It is great to see so much interest in this event on frailty and sarcopenia as core business. Something to bring to your attention is that all of our panel members here are not only members of the society, but have a number of portfolios and leadership roles within the society. And we welcome you to, if you're not a member already, to consider joining as a member. There's a number of benefits of joining the society and then also joining committees, beginning first of all with the events that we run, particularly thinking about the annual scientific conference, annual scientific meeting, opportunities for networking. And for myself personally, as I'm a physiotherapist, a clinician researcher, and in frailty, have been finding the networking especially beneficial, and that's from more deeper connections within the society, particularly in being involved in the early mid-career researcher committee. That being said, we will be putting out a call for to join the EMCR committee. So if you're interested, please keep an eye out for that. That call will go through the society. So either keep an eye on the society website, or if you become a member, then you'll be alerted with those emails. So we have a really dynamic and really rich committee, a lot of energy, and brings great networking, but also great opportunity to think about what we can do to help set the agenda for frailty and sarcopenia research in Australia and New Zealand. And we welcome your input into that. Today, Anthony Villani, who is the president-elect of the society and also an EMCR committee member, will be co-facilitating the event with myself. And in terms of the schedule for today, we'll begin with our panel discussion, and then we'll lead to a summary led by Anthony, and then closing remarks with Solomon. It's now my pleasure to introduce the committee, the panel members. So we have Solomon, Associate Professor Solomon Yu, who is our society president. We also have Professor Alan Hayes, who is a society counsellor. We also have Dr. Natasha Reid, who's also a society counsellor. And then we have Dr. Elsa Dent, who is a fellow EMCR committee member. And we also have Julee McDonagh, who is also a early mid-career committee member as well. So I'll now begin by opening the panel discussion. So I'll stop sharing my screen. Once again, we're very happy to have questions from the audience. We do have the Q&A function, so please do feel free to post in there, and we can include those panel questions, in the discussion with the panel, or that is something that we can address after the panel discussion, depending on what your question is. Okay, so I'll begin with the first question, which is for Solomon. So for Solomon, we have for you, in an ideal world, what would best healthcare for frailty and sarcopenia look like?
Oh, thank you, Jennifer. That's a very good question. It's almost impossible to get into an ideal world, but there's no harm imagining it, and that's what everyone tells me. Just imagine wild, and then you might get to where you are. I guess it depends on how we define what the healthcare system should be looking like. There's quite a big changes in the recent years in terms of what it should be looking like. In a broad sense, there's kind of broken down the community and then acute hospitals. And healthcare is not just when you're sick, but it's also when you're well. So ideally, you want to view frailty and sarcopenia and in a way that we need to think about it as a prevention. So in an ideal world, how should a preventive sort of medicine be practiced in the spheres of frailty and sarcopenia? So where I'm imagining it is where, like geriatric medicines, I guess if there's an geriatricians amongst the audience, you would, and everyone would agree that we need to look at it as medicine, not just medical doctors, but it's actually encompassing the allied health, dietitian, exercise physiologists in some ways to work very seamlessly and working together. We see that already happening in the acute hospital, but in some ways, they're still we are still growing into it. In the community, whilst that is the idea, it still doesn't quite work as well. So in my view is that there should be someone who, when you identify someone as a risk, perhaps, or needing to do some work for preventions, that we have a way to tap into it in a seamless way. That's my ideal world, somewhere to go, where they go, and all that sort of thing. So that's all been sort of seamlessly done. And it should be a team that actually seeing someone longitudinally as well. So that means that you don't have too many different people involved in just the one person's care, but at least you have a team that continue. I mean, if that is at all possible, that's what I think would be the best way. And then, of course, you cater for the individual needs. So you'll be able to sort of individualize the treatment options and allowing that to actually carry through. I would also think that in an ideal world, diagnosis is something that would be streamlined. Recently, I went to a conference. Now, AI has popped up in the world of frailty and sarcopenia, and how do we use the AI as a tool to help us diagnose. Now, if that is true and that can be done, I think that's actually a pretty good way. Someone could be just as early as someone who walked into the room, you already have the diagnosis, or there's a pop-up diagnosis or prompt to tell you that to look for those things. So technology is certainly something that is coming in the sphere. So AI is one, but technological assistance. So a new way of looking at it. How do we use technology in the spheres of frailty sarcopenia? So ideally, I like to apply those things in there. And of course, the cost is going to be considerations for that. But I guess in my view is that, if you invest now, you probably save a lot more later. That's my view. So that's my thinking around what would be ideal, that everyone works together for the individuals who have the same problem. Yeah. So that's my view, but I'm happy to hear any other input from the panels too, of what your ideal would be. The other ideal world, I haven't actually mentioned, so I did have a note here in thinking about it. Now, in an ideal world, you want to be able to work across, not just in the clinical front end, but also on the research side of things, so bench side to bedside. And I think that's really critical, because right now we don't have, whilst we are working together, we haven't actually linked those two strong enough to be able to have that cycle to provide the best healthcare. So research, bench side needs to actually link all together. and it needs to be live feedback, so you keep improving as you go along, rather than a lag behind in terms of the research information translating into practice. That's my ideal world. So you practice, you get feedback, you get improvement, and you keep doing that on the side. So that's my wish list.
That's excellent, Solomon, and thank you very much for that really great setting that future theme. We have received an excellent question from an attendee and links really nicely to your discussion. So I'll just open that up now. It's got a couple of questions, so I'll say them all together. What does the panel feel the role of an acute frailty unit is? What are the key components of an acute frailty unit model of care? Shall we start with?
We can open up that to the panel as well, but we could start with anyone on the panel with that one.
I'd be happy to start here. Yeah, so the rapid or the acute frailty unit will need rapid identification of frailty. We need to get something that we can get in like a couple of minutes. Are they frail? Are they not frail? Something that will inform decision making very early on. It might not be the most accurate ever, but we need something rapid. And we also need that person-centered care very early on, and just to make sure everything's following classic management. So we get equity in care, and that we're not getting any over-treatment, over-diagnosis, and giving the care directly what the patient would need. So there's a bit of work doing in the space in Queensland that I'm aware of, but I see the other hospitals in Australia are following in this, both in the intensive care and in the emergency department.
Yeah, I was just going to, I think what Elsa said, I agree with. And I think this is something that is being done, or it has been done for some time in the UK, where they're much more advanced than we are. So in my experience, I'm a registered nurse by background, and I haven't really seen so far, and I'm in New South Wales, that this sort of model of care is really occurring at all, which I think is a shame, because I think I mean, frailty is being implemented more, you know, in emergency departments and things, but just sort of that next level of, you know, a specific model of care for frail people in hospital. We're so far behind other places like the UK. So I do think there is a place for that. But I agree, it would be, like Elsa said, having the rapid identification of people, are they frail, and really that multidisciplinary model of care, which, as Solomon said, does happen, you know, in some respects. There's still a lot of siloed practice, but it still does occur to a degree quite well in some cases in the acute care setting. So I guess it's really about how frailty could fit in with that. But I guess it's really, and I had some notes for when it's my turn to speak more, but I think it's really about getting that buy-in from clinicians and just really letting people know how important it is to be not just assessing frailty and sarcopenia, but putting in that next management plan. So I think we've got a long way to go.
Natasha, I can see a hand up there. Go ahead.
Thanks, Anthony. Hi, everyone. Dr. Natasha Reid here. Just with the caveat that I'm not a clinician, but I did spend about 6 weeks in the UK with the Acute Frailty Network there. And they all had a slightly different model of care, but the one that, you know, I was told was the most successful or that worked best was when there was a general physician or internal physician paired with a geriatrician or someone who had been upskilled in geriatric medicine. That worked quite well for those acute frailty units.
Yeah, so I might just add quickly. I guess this is always a good question. I mean, should you have acute frailty unit? Should you call it that way, or should you call something else, or does it really matter? I guess we need to think of it, you know, the care for the older person as a whole, because frailty is one of the key components to it. So if you think of it in that way, then the role of whether you call it acute frailty unit would varies depending on locations of where you are, and what's available in your healthcare settings. So this is very sort of, I assume you are talking about it in the hospital setting. So it's kind of in that settings, can acute frailty unit play a role in anything? So just not really an answers, but just to sort of put it in the context of how you think about the role of any of the acute frailty unit. My view has always been that frailty sarcopenia tends to be most, if we do our job right, that then it should be a lot of community input to it. And so one is prevention and treatment. So it's just that currently we are kind of still building towards that awareness that acute frailty unit seems to make sense. When someone comes in, you identify them and you kind of do it. But in the future, whether that's going to continue to play the same role, that role could change. That certainly is one of the thinking. But what is the key component? I guess allied health is a big one. So if you think of how different it is compared to other units, then allied health, the strong presence of allied health is definitely one of the elements to it. But the other thing that I think over the time would improve, and I think you would find that as we upskills all the allied health, that that the model of care will continue to change. So in this unit, I imagine a lot of this unit would have specialized training in geriatric or gerontology type sort of background. So take occupational therapy, for example, they would have had quite a significant background to the training in looking after older person. Same thing for physio, same thing for dietitian. So you have that very specialized view and skills in managing those very frail older person. So what are the key components? I think one is the skill sets that's actually there, and the other one is that it encompasses a lot wider disciplines as well. So that's my view.
Waiting to see if there's any further discussion on that point. No. Okay. But I have well, one more question for you, Solomon, and also from input from the committee, the panel in just a moment. Where do you see frailty and sarcopenia management in the next 5 years in Australia and New Zealand? And this is a two-pronged question. So where do you see it in the next 5 years and where does it need to be?
Okay, so now I'm speaking from the society's point of view, and I do agree with our positions at this point in time. Where do I see frailty, sarcopenia management? I guess it's not just the management, it's the whole topics. Where do we go at this point in time? And I see that in the next 5 years, at least, that there is an increase in the awareness of the frailty and sarcopenia, and there's a significant increase in the upskilling process, as Natasha would agree with the Frailty Network, Australian Frailty Network. There's a lot of educational component to it and upskilling everyone in terms of the frailty management, diagnosis and management. And same thing for sarcopenia as well. We recently had worked jointly with the GP, with the support from Abbott, that now we come up with a primary healthcare algorithm in flagging those people who are at risk of sarcopenia or who has sarcopenia. So what I'm seeing is that you're going to see an increase in the awareness and possibly getting more management as well, because that's part of the sort of educational process. And where does it need to be? That frailty sarcopenia becomes part of the day-to-day management of any older persons, and that includes identifications of the conditions to appropriately manage the patients medically or in conjunction with the allied health. That's where I think we need to go through that. Now, I also would see that there's going to be a shift in this sort of management towards the community settings, and that's where I think that's where we need to go. Acute hospital presentations, after all, is only one small part of an individual's life. So they spend a lot of time in the community, and so I'm hoping that would actually be something that we will see an increment of it. You probably are aware that Commonwealth is now setting a lot more funding towards community and trying to do a lot more work outside of hospital in supporting older person to be independent at home. re-enablement program are just one of the examples of which they try to encourage people to be remaining independent at home. So the management tends to be, I suspect, will be more in the community settings. And hospital is going to be a shorter stay, treating the acute problem. The rest would be in the community. So I think that's really, in summary, where I think that would be in the next 5 years. I'm also I believe I will see more of the publications. Publication is a way to measure research activities. I had a feeling in this spheres there will be a significant increase as well in that space. I can't speak much on the sort of bench side, and perhaps Alan might have more thinking around the area. But I do hope that at least in Australia and New Zealand, given that we are a little bit more advanced in some ways, we already have existence, the bench sites research. We need a lot more research in informing the clinical practice. As it is, mitochondria has been implicated in our more recent conference in Melbourne. So I can start seeing some of those things happening. Genetics is another one that I see in the next 5 years. You're going to see more publications in that space. And already I'm seeing quite a few Americans paper coming out on that topics. So I'm hoping that that will start establish that link between bench side and bedside research.
Excellent. I wasn't sure if anyone from the panel had something to add at this stage. There was if I've given people opportunity, if I haven't, please at any time feel free to panel members to come off mute and so that make sure I'm driving everything okay. There was there are 2 questions that I can see in the Q&A. We have one from Naomi, and I think Naomi, you've got an excellent question, which we'll make sure to ask Solomon in just a moment. But one that leads really nicely on from what you were talking about just then, Solomon, is a question from Ju, who's also an EMCR committee member in the society. What's the idea of the panel on longevity clinics, given prevention is one of the priorities, and perhaps open that up to the whole panel about longevity clinics.
I'm willing to say something and stuff, hopefully not too controversial about it. I mean, I think the aspect of longevity clinics, I guess, is that people want to go to them to get a longer life, which is not necessarily, I think, should the focus be. The focus is a better, higher quality life. As long as the information and things that they're, putting forward and stuff are evidence-based and, safe, I think absolutely they have their roles. Most of the longevity clinics, if you look at what they offer, it's, slightly more than an average blood test. You get lots of imaging, so they'll look and screen for cancers. They'll do DEXAs for body composition. They'll do nutrition assessments, depression scales, and so they're really just giving you a very large scale analysis that you can't get when you go to a GP. A lot of those things may well happen if you go to hospitals, for instance, but of course these are all more about prevention than ending up at hospital. I guess the issue that I would have, unless they then get adopted by health funds, which hopefully is something that might come, because obviously you're then saving the money, is at the moment, from an equity-based aspect, they're really only servicing one relatively small part of the population, which is people who don't necessarily have those health disparities. So the people who can afford to go to longevity clinics are actually more likely to be educated, probably doing some of the right things already. And so you're actually missing your primary target audience. That would be my only issue and stuff with them.
Yeah, so I'm always I'll just add into this. I'm always fascinated by this idea about longevity clinic, and I guess it depends again, very much like the questions that you asked about acute frailty unit. What is the purpose and what is the goal of that unit clinic that is trying to do? If you talk about preventions, in some ways, I would say a lot of it has been done in the primary care already. So GP is actively looking at primary prevention. So you take cardiovascular system, for example, they would check the blood pressure, they would check the cholesterol. So that's actually already a prevention. But I suspect when they talk about longevity, they talk a little bit more than just prevention, I suppose, is what you then do to give your life longer. So it's not just preventing the problems, but to actually do things that increases, like you say, the time that you have, or maybe just becoming independent. So which is why I guess my questions and my the doubt in my head was, what is this longevity? How do they define longevity? And what is the purpose of it? I'm still trying to understand it, so I don't have an answer for that. I guess it probably would find its own way. In Australia, New Zealand, I'm just not quite sure where it fits in. I can see in certain country it kind of makes sense, but I don't know that Australia, New Zealand will take it off with that. But that's my view. Happy for other views.
Yeah, I can just add a little bit onto that. I totally agree. There is a difference between just lifespan extension and health span extension. And the idea of being able to maybe compress the period of time that we live with multi-morbidity with lifestyle intervention, that makes sense to me. I think everybody should have a foundation of moving their bodies, eating well, getting quality sleep, just those very basic things that perhaps in our society we don't do as much of as we should. I know when it comes to, I guess, some of the newer literature around longevity, there's certain drugs and things that have been repurposed, such as metformin for lifespan extension. And I would say, I don't know that there's enough evidence for lack of harm to do things like that. So yeah, I think it really depends on what we're talking about, like Solomon said.
These are excellent discussion and also exceptional questions that are coming through, and keen to hear your thoughts, Anthony. I thought these next three questions that are in the chat speak very nicely to opportunities and challenges, and perhaps we could go through these next that are in the chat, or we can continue on with.
Well, I could turn to the next question for Julie, and that they may get addressed there, and we can take it from there. So, Julie, understanding that you're predominantly in the frailty space, but what needs to be done to make frailty and sarcopenia management core business for healthcare professionals in the next 5 years?
Yeah, thanks so much, Anthony, and thanks to the committee for inviting me along to speak on this panel. I think it's a great event, and I think that's really such the golden question we're all interested in, isn't it? And it's certainly such a big question. I feel like we could talk for the whole time about what can we do. But I think Solomon already said there really needs to be greater education among multidisciplinary clinicians and health professionals regarding frailty and sarcopenia. So I think just, we know in the public, people still don't really know enough about what frailty is, and that it is something that we might be able to prevent components of, we might be able to slow the progression. I think there's just still appears to be such a lack of understanding about frailty and in extension sarcopenia. I predominantly work in the frailty space, and I have primarily worked in the acute care setting as well. So apologies if my questions and answers keep defaulting back to that place. But I think that the education, because even among a lot of clinicians, we try and talk about frailty, and they're sort of, the interest just still isn't there yet, or that they're not putting enough emphasis on how important it is. And I think that's frailty, as we know, since Linda Fried's work in Rockwood, which is actually over 2 decades ago now, first conceptualized frailty as the accumulation of deficits and that physical phenotype frailty model. People have been very interested in frailty. And, there's been, Solomon said, there's been such an increase in publications. People are really interested in it. And my background is actually working in the cardiovascular space. So I've become interested in frailty from a sort of a chronic disease perspective, which actually people can, start becoming frail a lot earlier due to their chronic disease processes, as well as, rather than just being solely age related. And people in the last 10 years or so in the cardiac space have been really interested in frailty because it's a great predictor for adverse outcomes. So I think that is where the shift needs to happen. We're still seeing a lot of clinicians and researchers and work coming out that's primarily having to look at frailty as a way to predict whether someone's going to come back to hospital, whether they're going to die within a certain time period, which is important and it's interesting. But I think now we have a lot of evidence that we know frailty can predict these adverse outcomes. So we really need to get that shift among health professionals and clinicians that frailty is much more than just a risk stratification tool. We need to be using frailty assessment as a way to plan the management of our patients that are frail. If it's people that are frail because they've got a chronic disease, we want to be starting to put things in place, because there's been a lot of work done that, we measure frailty, we show that they're at this greater risk, and then it's sort of, so what? So what are we doing about it? And over the years, my PhD examined frailty assessment instruments and comparing a few in a cohort of people with heart failure and presenting a lot of frailty work over the years. That would often be, one of the first questions people would ask, so we know that people are frail. What are we doing about it? So I think there really needs to be that shift, and it certainly is starting to happen. But someone that works in a clinical research space in a hospital, myself now, there still is a long way to go to get people to actually be more interested in frailty, and frailty as a way to plan care better, and not just to measure as something interesting we can have a look at, to really think of it as being something that we should be and assessing on everyone when they're coming to hospital, but not just assessing and not just screening for frailty, getting those multidisciplinary reviews in, like Solomon said, it's, having the allied health professionals involved, and really getting some lifestyle interventions in addition to their other, in conjunction with their medical treatments as well.
Julie, it's a really good point. I'll get you to hold that thought because I've got a bit of a follow-up question there for you, but I can see Elsa's got her hand raised there. So do you just wanted to add something to that there, Elsa?
Yes, so I come from the acute care, geriatric medicine, allied health primary care angle, so I'll talk more the primary care angle. So what we need, I think, to get that government expenditure and that awareness, particularly for clinicians, is the clinical pathways. So in Australia, we have health pathways for each region, and we need to get frailty and sarcopenia into the health pathways. Frailty is gradually creeping in there. I haven't seen sarcopenia in the health pathways, not in Queensland, New South Wales or SA health pathways. So we need to get sarcopenia, frailty written in there. So when GPs look up, oh, I've got a patient with who's older, they're at a false risk. Oh, look, maybe they're sarcopenic. Here is a clinical pathway here. So we need to bring that in. The other thing with government awareness is there's sort of that misconception of frailty and sarcopenia that it's a compulsory part of aging. We need research, we need awareness and policy to show that it's not a compulsory part of aging. We can prevent this, and then that way we can bring it into healthy aging policies, along with like nutrition, etc. So we need to not just do the clinical angle, but we need to bring it into that healthy aging policy and into the primary care space as well.
Absolutely, really good points there, Elsa. Just to follow up on my question to Julie, and obviously extend it to the panel as well. Julie, you mentioned around the need for upskilling in healthcare professionals for identification and then obviously management. What are some of the barriers here? What are some of the challenges associated with that?
Yeah, I mean, I think we've mentioned, I know at the conference that we had, our scientific conference in Melbourne, it was a topic that was brought up. There really is still siloing between practice, between clinicians in, I mean, particularly in the acute care setting again. We know that we've got access to a lot of people, the allied health dietitians, physios, exercise physiologists in some, that less so in the acute care setting, but, certainly in the primary care setting, there can be referrals made and people can access allied health visits as part of Medicare 5 per year. But I just think that the translation of that into practice just still isn't happening as best as it could be. So I think, you know, clinicians working together more. And I think sometimes, particularly with frailty, it's sort of clinicians, it's kind of like who wants to take ownership of the management of frailty, which I think it should be something we're working together with. It's not just one person's responsibility. You know, sure, I'm a nurse by background, and I know that we make up the largest numbers in the healthcare setting, and we could have a great role in, you know, screening or assessing for frailty and help with care, but it's not going to just be one person's job. It really needs to be working together. If there's that one person that might be able to make some referrals, you know, getting it into the care pathways, like Elsa was saying, it's all about that breaking down of the silos between different clinicians. And, you know, we know that something like exercise works so well, but people might sort of on the surface level be recommending some exercise, but, you know, what can we do if there isn't those exercise professionals present in the setting we're at? And, you know, what's the way forward? I think there needs to be some more upskilling in, we're talking about frailty for lifestyle interventions, you know, places that we can find the resources, or maybe some upskilling about other clinicians in how we can be recommending exercise to our patients in a more structured way that's not just, you know, go for a walk. We need to think beyond and thinking about, you know, the Asia Pacific Frailty Guidelines, which Elsa authored, getting, you know, people interested in resistance exercise and really getting clinicians to be talking to our patients in more detail about that, not just the surface level, that it's just something we tell our patients and it's not happening. And I had, another point that I think a challenge is, and coming from a cardiology background, we're still seeing a lot of times that the eyeball frailty test is occurring, or the end of the bedogram, whatever you want to call it. And, you know, I've even been to something recently where there was a cardiac surgeon there, and I got up and I spoke about how I've done some work where we've actually compared just clinicians estimating what someone's frailty is and then comparing that to a frailty phenotype. And it was so poorly. The comparison between the both was really poor. So we've shown that people, even clinicians that are experienced and, you know, they have a bit of knowledge about frailty, weren't able to identify if someone was frail compared to an actual instrument. So we know that it doesn't work, but it's still occurring. And it's occurring for people before they're, you know, they might not get to go for cardiac surgery because one surgeon thinks they look too frail. And to me, that is still such a problem. I think we need to talk about frailty management, but I think if that sort of practice is still occurring, that's still such a problem that we need to overcome as well, and educate that we should be using an instrument when we're assessing someone for frail. You know, the eyeball test and end of the bedogram, it really has no place.
100%. Just want to extend that same question to our other panelists in terms of some of the barriers and challenges associated with identification. Julie's had some wonderful responses there that are really on point, but does anyone else want to add anything else to that?
I can just say something here, Anthony, and mostly speaking about frailty as well. When it comes to identification and measurement in the frailty space, there are just so many different measures, and we have a lot of issues in, you know, not having consensus around what to use, and then it dilutes the messaging because the frailty measures are slightly different and potentially picking up people who might not fit into the same category. So yeah, definitely lots of measures out there.
Yeah, excellent point. On the flip side, though, again, maybe I'll start with you, Julie. What are some of the opportunities?
Yeah, it's a great point. I think there is a lot of opportunities, and we've probably touched on them already, but increasing focus on frailty in existing models of care. So while I see that there is a lot of work happening in the UK that we mentioned about acute frailty units, I think that could work. But then the flip side, when I think about it, I'm like, do we really need a specific unit just for people that are frail? You know, if we can't even get clinicians at the moment to agree that frailty is important, I just feel like that is so far off where we are in Australia right now. So on the flip side, I sort of think we know that there's a lot of existing models of care. So if we're going back to, you know, people with chronic disease, and my area is heart failure, there's existing models of care we know that work and that they're already in place. So I think it's rather than saying we need to do something completely different for people that are frail, the people that have a sarcopenia. It's about how can we increase the focus on frailty and sarcopenia in those existing models of care. So multidisciplinary team care is recommended and in place for a lot of chronic disease populations, and it's gold standard for people with frailty as well. So it's really about, I guess, getting the models of care to speak to each other more, or the clinicians involved in those models of care. So I don't really think it's necessarily about reinventing the wheel. It's about increasing the focus on frailty and sarcopenia in the existing models of care that we know are already working. And just bringing the point home again about the strong nursing and allied health workforce that can really be the drivers behind the frailty screening, assessment and management. And I guess having greater guidance regarding potential treatments and strategies to improve frailty for older people and those with chronic disease. So there's guidelines, some of the guidelines, the cardiology heart failure guidelines, we've got 2 sentences in the heart failure guidelines about frailty. So I really think in existing guidelines, we need to be having, more information within there about frailty and sarcopenia, rather than necessarily a whole new guideline for, the specific population. Multimorbidity is huge. People are frail. They don't just have heart failure. They've got renal disease. They've got liver issues. They're cognitively impaired. So I think that frailty really needs to be, core business in, the care of the older person, but also within different chronic diseases and from that multimorbidity approach as well. So, and I think when we're improving the messaging about frailty and sarcopenia in clinical settings, we also need to think about more patient-centered outcomes. So we're still probably very focused on, rehospitalization and mortality and very systems-related issues, but thinking, about patient-centered outcomes like quality of life is another important and, exciting opportunity. I think there's been more co-design work happening for frailty interventions, which I think is exciting and really important to have that community engagement with people as well.
That's excellent. Thanks, Julie. Really lovely responses there. Does anyone else want or would like to add anything else to the opportunities that exist in terms of identification and management?
Well, now GEM unit has been in existence for at least 10, 14 years now. So GEM stands for Geriatric Evaluation and Management Unit, and that's actually across Australia. It kind of modeled after the UK, what do they call it? OPA, Older Person Assessment Unit. So in some ways, that's actually in existence in many ways. I think the message is also getting through, although even though we don't use the word frailty, we don't use the word sarcopenia, but we know older person who had recurrent falls, who had cognitive dementia and all that. They are the ones that we take into Geriatric Evaluation and Management Unit, and is what it says, evaluation and management. So in some ways, that's already in existence. And in different parts of Australia, is what I've seen is that because of its existence, it's starting to sort of cut across different disciplines. People are becoming a bit more aware of, well, it's actually by definition frail older person who needed some more evaluations. At least they're in the system, they recognize that. Opportunity exists as well. I guess this is where I think the society is a good ground to grow leaderships in this area. People who explores the opportunity to become the leaders who are researchers leading in this area. And this is a good ground where we can then encourage more leaderships in this way, wherever you're going to work. And I think this is the ground where you can be sure what you're doing. You're on the right track, you have the support, and then be the ambassador going out and deliver the message. It will come with time. So that's a sort of informal way. And then formally, of course, it's engaging the government as a society in raising the issues. Frailty has in some ways make it there. Sarcopenia, I don't think it's actually, well, it's still up and coming. But I think that despite the ICD-10 code, that hasn't really sort of been taken on by the government. But I think in some ways they've kind of put it together. I suspect it's in the frailty as part of the biosubstrate of the frailty. But ideally, you like to see that sort of grow on its own. So opportunity is there, and the feeling is that the government is seeing there's a need to improve the care of the older person. That's a big umbrella rather than looking at frailty sarcopenia. But I think that's working in that space, working together. Yeah.
Thanks, Solomon. Yeah. Jen, I might handball over to you now in the interest of making sure that we're staying to time and schedule.
Thank you very much. So the next question is for Natasha, and I think this goes nicely from the discussion led by Julie, particularly thinking about practice change from your behavioural scientist background. So what are the key considerations for practice change to make frailty and sarcopenia management core business for health professionals in the next 5 years?
Thanks, Jen. Great question, and I'll do my best to answer it from a behavioural science point of view, although it is incredibly challenging, I think. So a couple of points come to mind. I guess what we've spoken about so far is that we need to increase awareness, both among health professionals, but also among consumers and the people out there to potentially go to their GPs and say, you know, I heard about this thing called frailty, you know, what is it? How does it apply? There's a lot of misinformation out there that it is only about those who are elderly or older adults, whereas we know that it most certainly can occur for people who are younger as well, depending on what other comorbidities or things they have going on. We do need to work on developing training and upskilling for health professionals, both those that are already in the workforce and those coming through university. So then thinking about it from a behavioural science point of view, unless everybody has a sort of personal coach in their pocket that can help them through these lifestyle changes for prevention or management, I think health professionals also need to be trained in behaviour change and how to do they actually convey these messages in very short time frames with their patients or clients. You know, routine screening and assessment is vital to sort of capture people who might be at risk of frailty, and then working out strategies that help clinicians to actually take that information forward. I think, like Julie mentioned, we don't want to just screen, we want to be able to do something following that. We've also talked a lot about multidisciplinary approaches or interventions, and while I totally agree with that, I think the other term that I've heard is interdisciplinary. So whereas multidisciplinary kind of refers to you know, having that exercise professional, that dietitian, and you go to them, in an interdisciplinary approach, they would sort of be coming to you and they're all working on your goals within their professions. So a very values-based approach to what people want to achieve in their lives, or, you know, if they need to get back to a certain level of functioning, for example. And then figuring out how to actually put these interventions into practice. So Elsa mentioned the health pathways, and we do absolutely need to integrate sarcopenia and frailty interventions, which are probably not too dissimilar to each other, into the healthcare pathways. And then the final two I had were around this sort of top-down approach as well. So we need the policy and the advocacy and the research to continue to improve on those aspects while we're training up our workforce, and they can help people on a more individualized level. Yeah.
A comprehensive answer. That was excellent. And I think within that, you talked about some of the opportunities and the challenges within one. That very nicely done. Opening to the panel, was there anything people would like to add, whether that be about thinking about practice change for health professionals, or thinking about opportunities or challenges?
I just wanted to, yeah, absolutely agree with Natasha around I guess the lifestyle or health coaching, whichever way, you know, how you want to sort of call it, behavioural change, aspects and stuff are so important. We know that exercise, nutrition, those things are good for people, and if you ask most people, they'll say, yes, I should exercise more, I should eat better. And then, of course, one of the fundamental questions is, well, then why don't you? So they know they should, yet they don't. And so, having all of the treatments, can align, doesn't mean that they're necessarily going to follow them. So absolutely, I think there's a vital role for incorporating that into clinical practice, and to help people get to where they want to get to and need to get to, but they may not necessarily know and understand. And I think that's certainly a vital point that's probably missing at the moment.
So I'll just add something to it as well, and all in agreement. Natasha, I think that's you're the experts in this area. Now, when we talk about practice change, we often think about changing the individuals. And Ellen, you're right. Why are you not doing it? I guess early on you asked about ideal world. So the other part of the ideal world in all of this practice change is about environment. And you may or may not have heard of the new projects coming out. I guess Canadians are leading this. It's about engaging in the environment, engaging the councils that changes the way the environment is set up, that encourages exercise, for example, and perhaps changing the content that's been sold in the supermarket, has some control over some of these things. Or some ways of calculating or indicating what is good for your muscles, and and all of these things. So changing the environment that sort of help to change the management of sarcopenia, frailty, if we think in that space, could actually work, and already trials is underway. So we'll be keen to see how that actually works. And it has to be consumer driven. So yes, changing individuals. So individual is hard to change, but if they work together with other larger group of consumers together as a group, chances of change is probably higher. So that's actually just a peer support, consumer support groups. So I think that's the other bit I'll just add in. Don't forget about the environment, because that's actually a key big one. Access to food is a classic one in geriatric medicines. If you are living so far away and you can't even get to the food, no point giving the advice on dietitian, dietary changes that needs to be done. So access to food, money. So that's the thing that we're going to be facing, inflation. So how are they cutting down their food and all that? So some of this is going to impact on the change. Obviously, we need to change that at the policy level, at the government level, but just bear in mind those would be an opportunity as well to encourage change.
Just waiting to see if there are any additional questions from the panel. Sorry, contributions from the panel. We have had a number of excellent questions in the Q&A, which we're working through with the discussion. Anthony, would you like to go with Elsa next, or any thoughts on what to discuss?
Yeah, no, sure. I'm happy to move on to Elsa. In terms of with a focus for the next 5 years, Elsa, what are the key strategic priorities for clinical research and striving towards best healthcare in frailty and sarcopenia?
Oh, thanks, Anthony. There are a number of areas we need strategic priorities in. First, we need that early identification and screening. We can have the best models of care in acute care, but the work I've done, we found that the older adults with frailty kept coming into the emergency department. So we need to get that frailty screening in earlier in primary care, even before primary care in the community setting. And we need to validate those frailty assessment tools in the primary care setting. We also need to look at biomarkers. There's a lot of emerging research in biomarkers and biomarker panels when you bring a group of biomarkers together, that cluster together, to predict who's going to be frail in the next few years, and bringing like community screening programs. They do that in Austria at the moment as part of their ViviFrail project. Jennifer and Solomon mentioned it earlier, we need that individualized interventions. We need individually tailored personalized medicine, like individually tailored exercise, nutrition specific for the older adults, and cognitive training and support that's tailored around a person's needs. We definitely need those multi-D models of care, those multidisciplinary models of care, which Julie mentioned a bit earlier. We need to integrate services. We need to integrate primary care, specialty care, and community services. As I think it was Natasha or Julie said before, we're currently siloed. We need our services to be a lot more integrated. So older adults with frailty are not missing out and sort of falling off the rails in services. And we need to develop care coordination and navigation programs to help navigate the healthcare system for people with frailty and or malnutrition. We also need that technology-enabled care. Solomon was alluding to this before, sort of like those wearable devices, mobile apps for frailty management, bringing in that AI. Just also noting that AI can sometimes be a bit ageist against older adults and sometimes a bit sexist or racist because it's just following what treatment we've given before. So we need sort of an overhaul there. And we also need that telehealth, link in frailty programs with good telehealth programs that are going at the moment. We definitely need, as Julie was saying earlier, we definitely need those person-centered care outcomes. So patient-reported experience measures that are collected in Adelaide with the Adelaide Primary Health Network for older adults. We need that across Australia, and that will be implemented soon as part of reporting in general practice for all patients. And we also need to investigate caregiver support and burden. A lot of older adults with frailty or sarcopenia, their carers are often the ones not eating, not exercising because they're looking after their person with frailty. Definitely need health services research as a big priority. We do lots of intervention research, but we need to have cost-effective analyses in there as well. We need to evaluate how effective these frailty programs are, and also ask older adults what they think, and ask clinicians what they think. Did they like the intervention? Was it good? Is it sustainable? Another thing, I think it was Solomon touched on earlier, we need the workforce development. We've done some work asking people why, allied healthcare professionals, why they're working in aged care and who didn't work in aged care. And we found that it was older females, sort of in their mid to late 40s to 50s, are liking, well, that's the other ones staying working in aged care. And why? They're not doing it for the money, they're doing it just because they like it. How can we train the workforce up more like that, particularly in the rural areas? We also need a lot of policy and advocacy work. Our allied health organisations need to lobby for the government. And I'm an exercise scientist, so ESSA, which is Exercise Science and Sport Science Australia, is doing a lot of work with the government trying to bring in more policies and stuff towards older adults to prevent that frailty and sarcopenia. We also need equity and inclusive, I'll just say equity. Equity, there's a lot of older adults with frailty that have, as I said earlier, having trouble accessing healthcare. How can we help them be involved in research about them? So yeah, we need to really bring in the patients and caregivers, and yeah, there's a lot of strategic priorities that we can put in. I've just listed a few there, but I think
Just to summarize, there's a lot to do. There's a lot to do, Elsa. Yeah,
yes,
that was really comprehensive. Thank you. And Elsa's identified a number of key strategic priorities, but just opening up to the panel from your perspective, from a perspective, say, of clinical research, are there any other key strategic priorities that come to mind?
There was there's a question in the chat which I was just reading, and it brings up a really great point. Someone has said that they work in a hospital coordinating a frailty study, and they're actually seeing that there's not so much at their facility a lack of awareness regarding frailty and the need for early identification and intervention, but they've mentioned the huge siloing between services and the lack of communication between care providers and different services. And that's something that we see a lot everywhere, I think, particularly for older adults. There's so many different support packages available. And I've got a PhD student that's been doing some work about transfer between when someone's discharged from hospital and when they go home, the amount of community support packages that are available for them, but people don't know what they are, or, you know, the My Aged Care package. there's so much information, and people can't even the health professionals working in the service can't make sense of what people should be referred to after they're being discharged and what support packages they have. So I think this is a real ongoing issue that there's almost too much, and I guess it comes back to communication between health professionals and with our patients. But there's a lot of overlap between services, and it's just trying to navigate the system is so difficult.
Absolutely. Elsa, you got your hand raised.
I was just going to say, one of the questions in the chat asks about diseases such as osteoporosis, and there's how do we need specific criteria, and that made me think of something as well. How about frailty? So the main gap here is in frailty, most of the research is conducted in high income countries, particularly in Europe, Asia, but there's hardly anything in the low to middle income countries. We need the research there, and we need to ask the older adults in the low to middle income countries, what do they like? What do they see as individualized care? What do they see as their barriers to accessing care? So I think that's one of the strategic priorities as well. Research in those low to middle income countries, populations with disparities in access to care, rural populations, those community linguistically diverse populations, the cold populations of refugees, the socio-economically disadvantaged populations. And I think we need more research there, because with frailty, we've got, back to the question, you've got the cut points there, but it's all European based. We need to bring in the rest of the world, and that needs to be in a priority. It's not just the high income countries with frailty. We're getting frailty going up through the roof in countries in the continent of Africa, for instance.
So you've touched on this a little bit, Elsa, but what are some of the other challenges in terms of being able to conduct this research, in terms of aligning these with the strategic priorities?
That's a very complex question. We've got just say that again, Anthony. I just
what are some of the challenges of being able to do all this research that still needs to be done? And that's a question that's open to the panel, not just Elsa.
Yeah, so what I think we need, frailty needs an ICD code. It hasn't been given an ICD code because it's not in the public space enough. It's not in public policy enough. That's one of the reasons that was cited. So I think we need frailty in that space. It's going great clinically. It started off in geriatric medicine, expanding to all specialties, but it needs more in the primary care community pool, healthy aging policies. I think that's what we need for a challenge, is to get that ICD code. And another challenge, I think, is bringing in engaging older adults. Julie was talking about that before. We need to really bring in those older adults, and we tend to not bring them in any research or any guidelines at all.
Yeah, agreed.
I was going to just add, Anthony. Oh, sorry, just a quick point.
No, go for it, Julie.
We need to get the funders and peer reviewers that are looking at our grant applications to be more interested in frailty and sarcopenia as a priority, because if you do a word search on some of the NHMRC outcomes over this year or previous years, you might once in a blue moon see frailty in the title of someone's grant application. So I really think that, and that comes back, I suppose, to policy. How can we get the government also interested in this as a priority? And funding the researchers to do the work in this country is a big problem.
Absolutely. Any other thoughts on that?
I definitely agree with Julie that there for the NHMRC, I put in an investigator grant, and the feedback is no, is that really, that is not important enough. So I've completely changed my approach now. I've looked at frailty, just cited the prevalence in over 50s. It's you're getting a lot of frailty coming in the over 50s, and then that's more of the population, and you're getting hopefully getting the peer reviews buy-in. But you're right, I do also do that, checking through who's got the right, how many in frailty, whoa, we got one frailty one. Congratulations, Julie, for that, by the way. But it's very, very rare to see frailty coming up in the grants. And we need to work together. We talk about siloed research, but we're all very siloed in Australia. We need to connect up together a lot more. And also industry partners. There's a lot of industry partners in aged care interested in the frailty space. We could maybe leverage funding from them. Hospital health networks up in the eastern states, and in Adelaide we've got our local health networks. We need to integrate everybody together in this frailty space. And I think we have a long way to go. To get those industry partners on board, I think is maybe a way way forwards, but it's hard work. Yeah.
Yeah, I can I agree with, Elsa, and sort of, getting industry and having numerous partners and stuff. I mean, we're living in an environment where the research spend as a percentage of our GDP has never been lower. And so, and one of the issues that's always been for, I guess, musculoskeletal conditions, and given that sort of osteoporosis, sarcopenia are sort of seen as sort of, muscle and bone, is those terms don't exist. Certainly muscle doesn't exist if you look in any of the research fields of research codes. The word muscle just does not exist, let alone sarcopenia. So, you're always going to some other panel, and other diseases have their own panels, cardiovascular panels, cancer panels. There's no sarcopenia and frailty panel. So you're constantly up against a number of other conditions. And even then the most 5 the recently announced national science priorities, the only one that's actually relevant to this is supporting healthy and thriving communities. So that's a very broad area, and will include things like green space, which is fabulous, but existing chronic diseases, child nutrition, equity things. So we're working in an ever decreasing pool of funding. So we absolutely need to be able to work together with clinicians, basic scientists, research groups, community groups, trying to lobby government, because it's only going to get more difficult. And that's one of the hardest things when terms like sarcopenia, frailty just don't really exist in the funding spaces.
Yeah, Elsa.
Yeah, I agree with Ellen. That's definitely 100% true. And just to leverage off what Solomon was saying earlier, I actually have statistics on that from my NHMRC investigator grant. Did you know 5 years ago, there were 22,000 papers on PubMed on frailty. Now there's over 45,000 papers on frailty. So the number of frailty papers has over doubled in the last 5 years. And most of it's coming into the specialties other than geriatric medicine. So the oncology, cardiology, surgery. Yeah, so I just thought that was an interesting statistic. That it's Europe, they're bringing in frailty as a priority, and it's working there, the early identification. And I think we need to say, hello, Australia, we need to catch up with the rest of the world there with regards to frailty and sarcopenia. We've done it with other conditions. We need to catch up with frailty and sarcopenia.
Absolutely. Good point, Elsa. In the interest of sticking to time and making sure that Alan has adequate time to answer some of the questions that are going to be fired at him shortly, I might just hand over to Jen now.
Thanks very much. I have a couple of questions for you, Alan. The first one being, what are the strategic priorities in basic science research for frailty and sarcopenia in the next 5 years?
Thanks, Jen. So fortunately, some of them are, related and similar to the clinical priorities, which is obviously a good thing, because you want to be sort of working to, together and stuff. From the basic science aspect, you still, the fundamentals of basic science is still the question, and that is the why. Why are things happening? What is driving some of these things? So, when we're talking about sarcopenia and frailty, we're not talking about just aging. And I think this is still one of the problems, is a lot of people just look at it as, it's just a natural part of aging. But no, why does it accelerate in some people? Why do people fall into those frailty and sarcopenic conditions? So a number of, priorities. One is to, have appropriate models of aging. One of the difficulties with aging research is that you either wait for, say, rats or mice to get old, which takes a long time and also is very expensive, or you've got to try to create models that recapitulate the changes that occur with aging. And we've got a castration and casting model that does quite well from a lowering testosterone, driving muscle mass down and causing strength loss in an environment of low testosterone, which is similar to what happens in males, but it doesn't reproduce the cardiovascular changes or the neural changes that are occurring. So I think we do certainly need to produce models that are appropriate and can recapitulate as much aging changes as possible, and then have measures and study designs that are translatable to as possible to the human conditions. From a focus of the sorts of areas that we're talking about, absolutely, I think you've got the biomarkers, works for many other diseases. Like there's now lots of cancer markers for different cancers. There's things like HbA1c for diabetes. The difficulty for biomarkers for aging is many things change with age, and a good biomarker won't do that unless you're getting sarcopenic and or frail. And so finding those sorts of markers is quite difficult. But I think it is an area where the newer technologies of now we can measure the metabolome, the proteome, the transcriptome, we've got massive amounts of omics possibilities and can utilize AI to really screen compounds, to really, I guess, investigate deeply and come up with new potential targets. It's difficult from the literature where you're like, this might work, and then you follow it and it may or may not work to varying degrees. COP cells, for instance, they were shown quite promise and stuff where they don't necessarily change with age, but shown to alter with sarcopenia, and there's still some work on those. But you're looking at factorial, conditions, multi-morbid conditions that are going to then presumably have to have multifaceted approaches. I think the AI thing is an interesting one, and I agree with what both Solomon and Elsa said around screening tools and quick identification. I think the opportunities for basic science is to go that step further and produce predictive models from those scans so that you can then identify people who are going to be actually at bigger risk of developing sarcopenia and frailty. So once you've got the AI so it can identify people, then it's a case of also then looking at people pre-frail, pre-sarcopenic, relatively healthy, and see what is it about, say, DEXA scans, CT scans, MRIs, blood work that is actually going to potentially predict how and why they might become sarcopenic. So I think those are certainly some of the the opportunities that and strategic priorities and stuff that we need to follow, which aligns well with the clinical space. And I think that's one of the aspects of basic science. Funding for basic science specifically, just straight basic science, is getting close to impossible in some ways. Certainly in HMRC, there's got to be the translation angle, and there's got to be clinical applications, or else it's just not going to go anywhere.
That was a sensational answer, Alan. From that, you seem to have answered in all of the follow-up questions that I had. Are there any other follow-up questions from you, Anthony, or anything that the panel would like to add?
I've still got one more thing around which I want to sort of, I guess, try to flip, like what Elsa said, is around the things and stuff, and it comes around things like the geroscience model and the hallmarks of aging. And what we need to do is to flick a number of these other conditions to say, well, no, actually, what we're doing if we're looking at changes with aging, be they mitochondrial changes, anti-inflammatory changes, dysbiosis, lots of things within those hallmarks of aging that basic science can look at and can investigate and then apply to, obviously apply clinically. Most of those things will also address cardiovascular disease, diabetes, and a number of the other comorbid conditions. So rather than them individually looking at, oh, I'm a diabetes research, I'm a cardiovascular and stuff, really, we should be actually the ones leading, and it's geroscience thing, because a lot of these things can be applied, and it's flicking that model around, which, as I said, sounds like they've got going quite well in places like the UK, but Australia is just, basically just dragging the chain on that one a little bit, unfortunately.
I just wanted to ask Alan if he could comment, because I thought you made a really great point when you were talking about funding for basic science, and that you need to have the clinical application and for a bigger application. How do you think that basic scientists and clinicians can work together on things like grant applications and project ideas? Because it's something, as a clinician, I haven't really worked much with basic science, so I'd be interested to know from your point of view how you think clinicians and basic scientists can work better together.
Yeah, it's always been one of the fundamental questions, and some areas are probably doing it well and others not. I think it's allowing clinicians to understand what we can offer as basic scientists, say, look, here's the sorts of things that we can do, and then discussing with clinicians as well, what are the sorts of questions that you want, that you want answered. I mean, if we, as I said, I'm absolutely fully behind the prevention aspect, but if we just talk about the treatment type aspect, one of the issues with not having frailty, having an ICD-10 and sarcopenia only recently is there's very little pharmacological approaches that can be, utilized, and most people with sarcopenia and frailty are actually going to be multi-pharmacological. So they're going to have lots of different things, and yet nobody's actually ever tested that. Most drugs are produced in isolation, and then you go, well, then we'll give this, and we'll give this other drug, and we'll see what that happens, and maybe they have contraindications. Those are sorts of things that we could easily be tested in, in basic science, to say, well, like, what sort of combinations would actually potentially address a number of the hallmarks of aging that might be useful in these conditions? What would they look like in say, organoids or primary muscle cells from, say, from human biopsies and or in an intact animal model to then demonstrate and show some efficacy and or side effects and stuff before you then apply them into the clinic. So there's always the possibility of two-way conversations. It's sometimes finding the clinicians are very busy, and sometimes they don't always want to know the why, and basic scientists are always interested in the why. So it's getting that sort of thing and go, okay, imagine you're only one person but you do two things, and then if you can get that, then the basic scientist doing the one half of it and the clinician the other half, but they're actually looking at it from the same outcome, which of course is patient oriented.
I think that's an excellent note to conclude our discussion. Thank you very much to the panel and to our attendees. It's been a really rich discussion, and I'll now hand to Anthony for a summary.
Absolutely, couldn't agree more. And I had to write some notes during that discussion, because there was lots of robust and passionate discussion, which was really wonderful. So first and foremost, I'd just like to thank all of our expert panelists here today on what was really a robust and informative panel discussion on some of the challenges and opportunities that currently exist in sarcopenia and frailty space, from the perspective of different areas of practice, whether that be clinical practice and healthcare, basic science and research, policy development, and so on. So like I said, I've taken a couple of notes to sort of summarize today's panel discussion, and what I've sort of really taken away from it is that sort of collaboration in healthcare. So this includes medicine and nursing and allied health is key from the perspective of identification and management of sarcopenia and frailty. Healthcare professionals certainly need some more upskilling, and there needs to be more awareness, but we also need to ensure that there's awareness amongst consumers or our patients as well. That becomes really important. That was a really pertinent point made by, I think, Natasha. It was a really good point there. We need screening for frailty and sarcopenia in primary healthcare settings. Yes, we absolutely need multidisciplinary care, but we also need to embrace the term of interdisciplinary care for the management of sarcopenia and frailty. We also need to streamline diagnosis, and technological assistance could be of value and assistance here. We also need to get clear and distinct clinical pathways to support diagnoses, which is a really good and valid point there made by Elsa. Patient-centered equitable care is another really important point here. In terms of where we go into the future, we need an increase in awareness and upskilling. I think I've already mentioned that one actually, but that was a really common theme today, sort of with respect to management and treatment. And this process is already starting to happen, but we will see an increase in this space. But in terms of where it needs to be, more screening, identification, and hopefully this will become part of routine standard practice in the near future. Obviously, ongoing continuous research is going to be important, linking the basic science to bedside-based research, but also development and integration of policy as well. We also need to support patients in order to help facilitate behaviour change from an intervention perspective as well. That's it was a really important point that was made today. And from a basic science perspective, the why is really important as well. Let's not forget about that. So the mechanisms associated with sarcopenia and frailty, they're still going to be important from that basic research perspective. This may also include finding biomarkers and predictive models to identify individuals who are going to be at risk of sarcopenia and frailty into the future.
An excellent summary, Anthony. Well done on such a rich discussion, bringing up excellent highlights. I'll just once again, there may be a few people who have joined, or as a gentle reminder that you're most welcome to join the society with membership. These are for the financial year, so please do consider. We offer a number of events, particularly the annual scientific meeting. And we also have our AGM coming up, great opportunities for networking, and we have international reach. So that's point of consideration. The other thing is that please also do consider joining our early mid-career researchers and clinicians committee. We will be posting for nominations shortly via our website. And also, if you are a member, you will then receive that as correspondence directly to your inbox via email. I'll now hand over to Solomon for the closing remarks.
Yeah, no, thank you very much, Jennifer, Anthony, and the AMCR committee. And I hope the attendees will find that this discussion has been most informative and helpful. And in fact, jot down quite a few ideas as well as we were talking. The opportunities that exist, and somehow, for some reason, we haven't thought about it, and it sort of came out on this one. So, which is great. Now, this will be the focus, hopefully, for the society to be driving. And for those who are attending today, you might see that there's quite a wide range of background of all of us, panel members. But in fact, amongst the members, we're all coming from different backgrounds. And that's one of the beauty of this society, is that we had clinicians, but we also had basic scientists. There's great opportunities to work together in that space. And yet we need more hands. You hear there's lots of issues and questions that we need to answer. I'd like to also say that this is actually a good ground to grow yourself as a leader. I'm sure now Anthony is our president-elect. As he takes over, there'll be a lot more. I'm sure, I'm looking forward to that. There'll be more activities that we could create that opportunity for collaborations and networking. So please watch that space. And as Jennifer said, we have the AGM coming up in a couple of weeks' time. I have invited a speaker, as Julie mentioned, the cardiovascular background. So incidentally, the speaker's going to talk about sarcopenia and cardiovascular system. So I think that will be a very interesting one to sort of attend. So I kind of encourage everyone to consider joining us for that meeting. And the notification will be sent out shortly. So I think in summary, I think this is a great event, and thank you so much for making this possible. And I do hope that we'll have new members joining us as well, as continuing with the work that we are doing. Thank you very much.